Good morning, ladies and gentlemen, and welcome to ASTRO 2021. We're so happy that you're here today. Now, we're very excited that we have a robust schedule here at the Aero Academy. The Accuray Exchange for Radiation Oncology is a peer-to-peer network that is designed to really allow the radiation oncology community to mix, mingle, share best practices, and continue to enhance what we're able to accomplish clinically using radiation therapy. It is my absolute honor to introduce Dr. Jonathan Haas from NYU Langone Health, NYU Langone, Long Island, who will be speaking to us today about the use of CyberKnife for prostate SBRT. Dr. Haas is an absolute expert and has been an innovator and pioneer within this segment, and so we are so honored that he has chosen to speak with us today. Dr. Haas.
All right, so I'd like to thank Accuray for allowing me to give this talk today, and the title of my talk is going to be Rationale and Overview of CyberKnife Prostate SBRT, so put your seatbelts on, we're going to try to cover a lot of ground. These are my disclosures. So radiation for prostate cancer has evolved over the past decades. LDR brachytherapy was brought up from Scandinavia in the late 80s, 3D conformal in the 90s, HDR brachytherapy in the mid-90s, IMRT in the late 90s, IGRT and protons in 2000, and the very first CyberKnife patient was treated in 2003. And as a radiation oncologist, I think most of us know that everything works, right? So given that, my concerns as a radiation oncologist are controlling the cancer and minimizing side effects to the normal surrounding anatomy. I want to maintain quality of life, and I want to make sure it's convenient for patients. So just as far as the radiobiology of prostate cancer, so we know that cancer cells and normal cells respond differently. So early responding cells have something called a large alpha beta, which means that they're less sensitive to changes in fractionation, and it's typical of most tumors. That's why we give radiation over 7, 8, 9 weeks. Late responding tissues have a smaller alpha beta. It's a larger proportion of non-cycling cells, and interestingly, prostate cancer as well. So why should we fractionate? So dose protraction will spare late responding normal tissues much more so than tumors, but this assumes that the alpha beta for tumor cells is higher than the alpha beta for normal responding cells. Alpha beta for prostate cancer is low. There's a lot of radiobiology studies that show that it's much lower than other cancer cells that we treat, on the order of 1.5. So if we know that the alpha beta for urinary side effects is 10, for rectal it's a little over 5, prostate cancer has a lower alpha beta than the alpha beta for both early and late sequela. So there's no rationale for dose protraction, in my opinion, for prostate cancer. Given that the alpha beta for prostate cancer is less than that for the normal surrounding tissue, there's no radiobiologic rationale for doing 9 weeks of radiation. There is a rationale for escalating dose though. So this is a paper from Jack Fowler where he compiled data from multiple centers, and you have to give, you see that the dose response curve, I don't know if this laser point is going to work, but the dose response curve kind of flattens out about 90 gray. So you have to somehow get over that plateau to get a maximum response. So if we know that the alpha beta for prostate cancer is 1.5, giving a dose of 7 to 7.25 or 8 gray, which is what we do, kind of takes you up in that mid-90 or higher gray. So that's really the sweet spot that you have to aim for. And there's nothing new about this. So this is Sir Laurence Olivier, the famous actor. He was treated in the 1960s with prostate cancer. He had a week of radiation. You know, obviously not classic SBRT as we know it, but even then radiation oncologists knew that the biology of prostate cancer was such that it supported giving the radiation over much faster periods of time. And he died in his 80s of not prostate cancer. And this is data from that era. So this is a paper from Dr. Lloyd Davies where he looked at over 200 patients who received a week of radiation in the pre-PSA era, and no difference in survival compared to the general population. So we're not reinventing the wheel. So the low dose older era was doses less than 70 gray. Enough dose in the modern era was 70 gray or more. Moderate hypofractionation is giving a higher dose per fraction over a shorter treatment time, and ultra hypofractionation, if you want to call it SBRT, SABR, whatever you want to call it, is a very short course given radiation for 1 to 6 days. So ASTRO slowly has been coming to grips with making this standard of care. So in 2011, the highest scored abstract at the plenary session was a paper from Alan Pollack. This was the first moderate hypofractionated trial that was ever published at ASTRO, and they looked at over 300 patients. 150 patients had conventional radiation, 38 fractions, and the other half received an accelerated 5-week course of radiation. And the biochemical NED, or no evidence disease, was 85% for both arms. And Pat Capellian got up as a discussant for ASTRO and said, as this trial shows equivalence between conventional and hypofractionated radiation for prostate cancer, this should be the new standard of care as it's quicker and more convenient for the patient. So the first baby steps that ASTRO took to make the standard of care. And there's been a bunch of moderate hypofractionation trials, RTOG, PROPHET, CHIP, gave 300 times 20, and you can see that the biochemical NED was identical in both arms. So we know now, at least with good randomized moderate hypofractionation data, that this should be a standard. So what about ultra hypofractionation? So this is my partner John Lashak, who's in the audience, and Seth Blacksburg. This is, I think, the new standard of care. So is SBRT experimental? So in 2008, ASTRO had a white paper, and they said that at that time there was not sufficient or mature data, and it should be not yet a standard of care. So that was 2008 when ASTRO was kind of giving us a harder time. And then the first 5-year paper came out from my friend Deb Freeman and Chris King in 2011, where they looked at 41 patients treated on an IRB-approved protocol, which is what ASTRO had recommended. They gave 725 times 5, which is still considered a standard of care dose. And the biochemical PSA control was 93%. So this was the first IRB approved trial showing equivalence with classic SBRT doses. And this is paper from my institution, from my former partner Alan Katz, looking at over 500 patients treated on a CyberKnife, 9-year data, and he broke it up by low risk, intermediate, and high risk. And you can see the data for low and intermediate risk was excellent. High risk dropped a little bit, but in line with what you would expect with conventional fractionation. And he found no difference whether we gave 7 times 5 or 36 or 725 times 5. So we go back and forth still in my institution a little bit. And this is 10-year data. Again, all patients treated at NYU Long Island, over 200 patients treated on a CyberKnife. And this is 10-year data showing a biochemical disease-free survival of 93% with an excellent PSA nadir. At this conference center at ASCO a few years back, I presented on over 1,200 patients treated at NYU Long Island, all given 7 to 7.25 and 5 fractions. And I make this red here because if you go to some of the gantry-based systems, Varian, Siemens, Elekta, they're going to talk about giving 8 gray times 5. But they're prescribing to a much higher isodose line. So they're prescribing to 95, 96, 97. So we're prescribing 7.25 to the 83 to 85%. When you translate the doses out, it ends up being higher than what some of the other centers are getting. So be careful when you do give your dosimetry. And you can see that our median PSA just plummeted over time. So this is the paper that Seth, Aaron, and I did at ASCO a couple of years back. So we concluded that SBRT using a CyberKnife was extremely well tolerated and efficacious, and we confirmed prior reported series with a much larger number of patients. This is a paper from my friend Bob Meyer, looked at 21 centers, over 300 patients, broke it up by low risk and intermediate risk, all CyberKnife. And again, if there's any clinicians in the audience, be careful. Bob gave a dose of what he said was 8 gray times 5, but it's much more, again, I have a course and we go into this, it's actually more like 7.25 times 5. And this is Bob's data. The 5-year disease-free control was 95% for the whole patient, 97% for low risk, and then he broke up by low and high intermediate with your Gleason 3 or Gleason 4. Not surprisingly, there's a slight decrease in outcome, but 93% I would argue is as good as any data that you're going to get for prostate cancer. My friend Don Fuller, the madman who I love, talked about 259 patients treated at 18 centers, and he gave 38 gray and 4 fractions. Bob doses a little bit differently than the rest of us, more like kind of HDR brachytherapy, but you can see 100% control at 5 years and 88.5% with intermediate risk, and he also nicely broke it up by high and low intermediate risk prostate cancer. This is the PACE-B trial, which I think Dr. Tree is going to be speaking about later today. But this is a neat trial that was sponsored by Accuray. It's a 2-arm trial. So patients that are surgical candidates are randomized to radical prostatectomy versus SBRT. And if you're not a surgical candidate, you are randomized to SBRT versus conventional fractionation. PACE-B results are starting to come out now. So if you look at the PACE-B, this is the arm that was randomized to hypofractionated versus conventional radiation. And you can see that the side effects were the same in both arms. So they concluded that giving hypofractionated radiation does not increase either GI or G side effects. And then interestingly, just last month at ESTRO, and I don't want to steal Dr. Tree's thunder because I think she is speaking here, but they just published this last month. And in the SBRT arm of PACE-B, patients that used a CyberKnife as opposed to a gantry-based platform had significant improvement in toxicity compared to the other platforms. And if you look here, this is PACE-B by platform. This data is 1 month old. Patients treated on a CyberKnife, the GI and GU toxicity was significantly less than if you had a gantry-based platform. So this further supports, if you're going to do this, I think, doing it on a CyberKnife with the highest quality of data. Phase 3 data shows that this is a better platform, in my opinion. Other randomized trials, so this is the Widmark trial. Patients were randomized to 7 fractions at 42 gray versus conventional fractionation, and then the RTOG was a 2-arm moderate hypofractionation versus SBRT arm. This is the Widmark trial. Again, this is a phase 3 trial, so the highest level of data. It's a coin flip. Patients are randomized to either SBRT or conventional fractionation, and they looked at 1,200 patients, so a real number. This is a great paper, I think. Intermediate to high-risk prostate cancer. We'll come back to this a little bit when we talk about high risk, but these were the criteria, the eligibility. And the results were great. You can see the curves are superimposable, whether you had conventional fractionation versus ultra hypofractionation. So with the highest level of data, there was equivalence with 5 fractions as opposed to 9 weeks. So again, why should you ever do 9 weeks for prostate cancer? I don't think you ever should. Toxicity was essentially the same, a slight increase in the short term with the hypofractionator arm, but you can see by 1 year it resolves to baseline. So they concluded that with a median follow-up of 5 years, SBRT is non-inferior to conventional fractionation. There was a slight increase in acute side effects, which we would expect, but this resolves with late follow-up to standard radiation, and you're done in a week. So introduction of hypofractionated radiation offers patient convenience and significantly reduces radiotherapy department workloads. RTOG 0938 was a randomized phase 2 trial looking at 7.25 times 5 and a 12 fraction regimen compared to historical controls. Over 250 patients were treated, about 3/4 on IMRT or VMAT, and the remainder were treated on a CyberKnife. And again, you can see lines are superimposable, so side effects for bowel, for GU, for sexual, all identical, and the disease-free survival, which in my opinion is the most important thing, was equivalent between the 2 arms. So they concluded that the 5 and 12 fraction ultra hypofractionated radiation was well tolerated. Patient-recorded outcomes were comparable to that for standard radiation. And they're continuing to follow these patients out. So does dose matter? So Michael Zalewski, and I'm going to give shameless plugs, we have an SBRT course every year. This year it's going to be hopefully back on site in Scottsdale. Michael's on our faculty. And he looked at 5-year outcomes of a dose escalation trial with SBRT. He had 136 patients, not randomized, enrolled, and started at 32.5 gray, 35 gray, 37.5, and 40 gray. No differences in toxicity between the dose escalation arms. And there was a trend toward improved PSA, which is not surprising with the higher doses. Or 3 years, your PSA went down a little bit better with higher doses. The biochemical relapse was a little bit better with the higher doses, which kind of makes sense. The 2-year biopsy results also were better at 2 years with the higher dose. But interestingly, in patients that have a positive biopsy, if you look at this last line here, really a low number actually had a documented PSA failure. So the question becomes, and I've asked Michael this question, what do you do when you have a positive biopsy, but their PSA doesn't meet Phoenix criteria, which is what we determine as a failure? He just watches them. But interestingly, there was a paper published in 2013 where instead of 2-year biopsies, they looked at 3-year biopsy. So with the doses that we use at my institution, 7 to 7.25 times 5, the numbers dropped. So it may be with longer follow-up that that 7.25 still is the standard dose. That's what we're comfortable with, or we are looking for some protocols that were involved with escalating a little bit. So Dr. Zalewski concluded that SBRT doses from 32.5 to 40 gray were well tolerated, and biopsy outcomes at least at 2 years suggest improved rates of turbine clearance with the higher doses of radiation. So what about for high risk? Shameless plug number 2. Mark Kashan gave a paper who's going to be at our course. And he looked at a multi-institution analysis of high-risk prostate cancer, all treated with SBRT. And these are their results looking at 182 patients with high-risk disease. This was the eligibility. Standard doses, 7 to 8 gray times 5. Amar, I think, does use a gantry-based system. So again, his 8 times 5 is probably the equivalent of our 7 to 7.25 times 5. And you can see that the 5-year biochemical freedom rate was 85% in those patients that received hormones, and you did see a decrease in patients that did not have hormones, and that's a separate discussion. But at least in his multi-institutional study, SBRT demonstrated an acceptable side effect profile, Longer term follow-up is needed, but given the potential higher incidence of biochemical recurrence without hormones, probably still has an important role, at least for your high-risk patients. And in my institution, the vast majority of patients with high-risk prostate cancer do receive hormonal therapy. This is the Widmark trial that I showed earlier. It was intermediate and high risk, and 11% of the patients had high-risk disease in that protocol, randomized to 7 fractions versus conventional fractionation. And you can see that the lines were superimposed with high-risk disease, although Amar said, when he gave this talk, he said the small proportion of high-risk patients in the study didn't allow any conclusions for hypofractionation. But again, at least these patients were included in the SBRT arm. So does size matter? This is a paper that I had the privilege to edit from my good friend, the Collins brothers at Georgetown, where they looked at SBRT for prostate cancer patients with glands greater than 50 cc's. They looked at 57 patients with prostate glands, minimum of 50 grams, treated with SBRT. The median prostate size was 63 gray. Again, same doses that we give, 7 to 7.25, but again, low isodose. If you're a clinician, don't just fire away and give these doses. Make sure you know what you're prescribing to. That's why I always say read the paper. A third of patients received hormones prior to treatment. About half the patients required Flomax, which we prescribe like candy in my department. 3% had very low grade 3 toxicity. So very, very good outcome for patients with bigger glands. Less than 2% GI toxicity, no grade 3 toxicity. So Sean concluded that patients with larger prostate volumes can be safely treated with SBRT. GI and GU toxicity rates are comparable to even better than those with other forms of radiation. So their paper supported the growing body of evidence for effectiveness of SBRT even for larger prostate glands. So John Lashak and I decided to take this even bigger. So this is what we call our Mega Gland project, which is presented at this meeting this week. We looked at 67 patients with glands larger than 100 cc's. All treated with CyberKnife. 18 patients received hormone therapy. All patients had to have a final gland size greater than 100 cc's, regardless of receiving ADT. Again, same doses that we always give, 7 to 7.25 times 5. And then John Lashak was wonderful about breaking out all the data much better than I could. But our mean prostate volume was 139 cc's. The median PSA was 8.7, dropping to 0.5 at 2 years. We did see a decrease, not surprisingly, in EPIC bowel and urinary scores at 1 and 3 months, but by 1 year improved to baseline, and by 2 years it was actually above baseline, both for GI and GU toxicity. So even for these big mega glands, at least in our hands, we think it's perfectly safe, because out in the community, like we hear, it's too big for CyberKnife, it's too big for SBRT. I think this is one of the first papers that showed with really, really big glands that this can be safely done. So this is the mega gland conclusion. I love John's word. SBRT is demonstrated to be oncologically effective with minimal toxicity and more ubiquitous. Thank you, John. Radiation option in men with localized prostate cancer. Although there's a historical reticence for treating men with large glands, we showed that our biochemical relapse-free survival was 5%, and the grade and the toxicity was incredibly low. So I think we can do this safely. So what is CyberKnife? It was invented at Stanford by a super charismatic neurosurgeon. And he came up with the idea of combining two things that had never been done before. He put chocolate and peanut butter and treated cancer with it. So what he did is he took a KUKA robot, which is the robot that you use to build cars. He miniaturized the linear accelerator and he gave it intelligence. So this is a typical S7 CyberKnife. We have 2 of these at my institution, consisting of the X-ray sources, the image detectors, the manipulator arm, the RoboCouch, the linear accelerator, and either exchange table, or now with the MLC. And it's super accurate. So I see Jim English in the audience. When the salespeople come, they say, well, our machine's more accurate. What does that really mean? Well, there's a lot that goes into accuracy, right? Treatment planning, beam delivery, imaging, patients are gonna move, and all that has to be taken into account when we do our planning. So CyberKnife has mechanical accuracy of 0.2 millimeters. What does that mean? Right, as a clinician. So I want to see data. So this is old data that came out of Stanford and Colorado, looking at the clinical accuracy of using a CyberKnife. And you can see that the clinical error, meaning taking all that other stuff I just showed you with all those big circles, is 0.7 millimeters. So this truly is, I think, the only system that has sub-millimeter clinical accuracy. And that's super important. Why? Because the prostate's a moving target. So Pat Kapelian showed that the prostate's going to move at least 3 and 5 millimeters for 30 seconds or more during treatment. So if your margins are 3 millimeters, but your prostate's moving 5, you missed. So we have to make sure that if we're going to give these big doses of radiation, we have to be on point with it. And the prostate moves like an airplane, X, Y, Z, pitch, roll, and yaw. So you have to compensate for all those degrees of motion. So the way that we do is we place fiducial markers. All patients receive 4 gold or platinum markers. We do this in the clinic. We probably do about 15 to 20 a week. Local numbing, no anesthesia. We asked the company to make the needles double loaded. We used to have singles, but it's just 2 needle sticks now. We no longer use amifostine, but we did. And now probably 80–90% of our patients receive hydrogel spacer. These are the fiducials, and you can see they're double loaded. So it's only 2 needle sticks, takes 30 seconds tops. And this is a typical treatment plan looking at very conformal doses of radiation to the prostate and much lower doses of radiation to the normal surrounding anatomy. And the nice thing, this is a neat paper that Seth and I presented at ASTRO a few years ago. By having a non-coplanar, meaning the beams are coming in at hundreds of different angles as opposed to a hula hoop, with a gantry-based system, we can avoid things like the testicles, right? Prostate cancer, by definition, is a disease of men. Men like to be sexually active. So we're able to show that we can reduce the testicular dose to 11 centigrade when we make that a testicular avoidance structure. So not only are we curing your cancer, getting back to the second slide of what are my concerns as a radiation oncologist, I want to cure the cancer, but I want to make sure the patients have minimal side effects. And what about the cost? Who doesn't love Snoop Dogg, right? So it's more cost effective. And this is some of the stuff that I see Sean Princeton that helped me with some of these slides. So if you look at, this is at my institution, so IGRT is $40,000. IGRT plus 2 years of hormones is $77,000. CyberKnife is $28,000, so it's cost effective. And this is a paper that's published at JCO. Protons were $115,000, IMRT is $59,000, SBRT across the spectrum is $50,000, so it's more cost effective. So SBRT, regardless of the system, again, we're biased toward a CyberKnife, provides 3 to 5 times greater capacity than your conventional LINAC. So if you figured that your average SBRT is going to be at 3 fractions compared to 5 weeks, I think that's starting to come down a little bit with hypofractionation. You can treat 5 times more patients for the same outlay of capital on your linear accelerator. It's safe. This is data, this is physician-reported toxicity. You can see both for urinary and GI toxicity, all the lowest side effects were with SBRT, and in this year, pretty much all of them were CyberKnife treated. Patients like this. So this is a survey from the CyberKnife Coalition. They just asked patients, 99%, this is patients giving the answer, said treatment was a success, 98% would recommend it to others, 93% said there's no interruption in normal routine, and 99% would choose to be retreated, and since this is a CyberKnife survey with a CyberKnife. So that's powerful. So in conclusion, higher doses given safely equal better radiation, equal better treatment. Fewer and less invasive treatments, provided that you have comparable results, and I think I just showed that, is better convenience and quality of life for the patient. And this really is, I think, the golden era of SBRT. So this is a paper that Seth and I presented at ASTRO a few years ago, and you can see these are all abstracts presented over the last 20 years at ASTRO, and the one group of abstracts that is going up while everyone else is going down is SBRT. So this truly is, in my opinion, the golden era of SBRT, and I think CyberKnife is a system that was the trailblazer and is specifically designed to do this, and as the PACE-B trial shows for toxicity, I still think it's the safest trial to do it. So it's better, faster, and cheaper. I love giving this slide. So Jack Welch, the legendary CEO of GE, who was a friend before he passed of my department, said I was never the smartest guy in the room. If you're a leader and you're the smartest guy in the room, you got real problems. So I work with a group of people, and I am far, far from the smartest guy in the room, but I work with them. So this is Matt Witten, our chief of physics, John LeShock, who's in our director of our CD CyberKnife, in charge of research, Todd Carpenter, who is associate director of clinical operations, Aaron Katz, who's our chair of urology. And again, for those of you starting a program, just have your urologist have buy-in. It makes it easier on every level. Astrid Sanchez, who's my assistant and the real chair of the department, Chris Mendez, who runs our database, Owen Clancy, our associate chief physicist, and Harold Stephen, who's our administrative manager for Manhattan. So this is my favorite place on the planet. This is the Long Beach Boardwalk, where Josh and I grew up. So thank you so much for your attention. I hope you got something out of this big ton of stuff I just gave you.
Wonderful talk, Dr. Haas. So thank you for him to talk about the efficacy, the tolerance of SBRT for prostate treatment, and the case for CyberKnife and how it's really helped them to achieve that dose conformality and achieve the best outcomes for their patients. And so what we'd like to do right now is open it up for any questions from the audience. Does anybody have a question that they would like to direct to Dr. Haas here? Dr. Haas, I think it was just so thorough and so informative that there's just no questions.
Go treat patients.
Go treat patients. Absolutely. Thank you so much for your time, Dr. Haas.
Thank you.
Fantastic talk.
Thank you.
And for those of you who are here in the booth, please make sure to join Accuray throughout the rest of the show. We have wonderful demonstrations that are going on. There is a very robust Aero Academy program that will be remaining throughout the rest of the show. And we do have a unique VR experience for you to see our Radixact in action. So please join us through the rest of the show and have a fantastic rest of your Astro.